The year is around 1300 BCE. An Egyptian soldier takes a spear through the forearm on the edge of the Nile Delta. The healer who reaches him first does not pray, does not chant, does not guess. He packs the wound with honey and wraps it in linen, exactly as the Ebers Papyrus will later record, and the soldier survives. Not because the healer understood bacteria won't have a name for another 3,000 years. Not because the healer had any theory worth writing down about why the honey worked. He had something older and more useful than theory. He had pattern. Enough men treated with honey who didn't die. Enough wounds left untreated that did. The pattern outlived the men who first noticed it, passed from hand to hand down a chain of healers across centuries, long before anyone could explain the mechanism underneath it. That is a question worth asking, not whether ancient medicine was advanced. It wasn't, not by any standard you'd recognize. The question is why certain remedies produce better survival odds despite the complete absence of any correct explanation for why they should work at all. And the answer, when you run through the evidence, is that a handful of healers across a handful of cultures landed on substances that had actual mechanisms buried in them. Real chemistry, real effects on living tissue, found entirely by watching what happened next. Honey is the clearest case. Egyptian physicians used it on wounds for at least 3,000 years before anyone studied it formally. The mechanism, once science caught up, turned out to be layered. Honey pulls water out of tissue through osmosis, drying the local environment so bacterial cells cannot maintain pressure across their walls and collapse. It also contains hydrogen peroxide, produced slowly as glucose oxidizes, and in some varieties compounds that inhibit microbial growth through separate pathways entirely. An open wound packed with honey in 1300 BCE was a wound sitting inside a hostile environment for infection, not because the healer knew that, but because honey, by its chemistry, simply is. The Greeks and Romans arrived at wine and vinegar through the same blunt empiricism. Hippocrates, writing in roughly 400 BCE, recommended washing wounds with wine or diluted vinegar rather than river water or nothing. Neither he nor his students had a germ theory. What they had was generations of observation that wine-washed wounds closed cleaner and rotted slower. The acidity of vinegar, its acetic acid content, creates a pH that most wound pathogens struggle to survive in. Wine carries polyphenols and ethanol. Neither is as effective as what a trauma surgeon uses today. Both are substantially better than leaving the wound open to contaminated water, which is what the alternative looked like. Then there is debridement, the act of removing dead tissue from a wound. Healers noticed, without understanding cellular death or anaerobic infection, that flesh which had turned dark and soft needed to come out if the patient was going to survive. The method varied by culture. Roman military surgeons described cutting away necrotic tissue with iron instruments, but the oldest continuous form of debridement was one that required no instrument at all: maggots. The larvae of certain fly species eat only dead and infected tissue, leaving living cells untouched, a selectivity that modern wound care practitioners rediscovered formally in the 1930s and still use in resistant cases today. The ancient world didn't theorize this mechanism either. They observed that wounds visited by certain larvae healed when comparable wounds did not. Willow bark sits in a different category. It manages pain rather than infection, but the mechanism is as real as any of the others. Healers in Mesopotamia recorded its use for fever and inflammation around 3000 BCE. Hippocrates described chewing willow leaves for pain. The active compound is salicin, which the body converts to salicylic acid, a chemical cousin of aspirin. Every person who chewed willow bark for a throbbing wound or a joint that wouldn't settle was receiving something with a genuine anti-inflammatory pathway running through it. The relief was real. The explanation on offer, depending on the culture, was not. But the effect in the body ran regardless of the story wrapped around it. Here is what those four examples share: honey, wine, and vinegar, maggot, debridement, willow bark. None of them required a correct theory to function. Each one had a real mechanism that the surrounding tissue responded to, whether or not the healer administering it could articulate why. The ancient world did not discover these things by reasoning from first principles. It found them by the same method your ancestor used to track a gazelle across a dry plain: watching, comparing, remembering what happened when the wound was treated one way versus another and passing the pattern forward. That is not nothing. That is not primitive superstition dressed up as medicine. That is empiricism without the vocabulary for it, pattern recognition before the tools existed to explain the pattern, operating on the same tissue, the same wounds, the same infected flesh that a physician would be confronting 2,000 years later. But the same logic that led healers toward honey also led them somewhere else entirely. And that is where the story turns. The same observation that saved the soldier with the honey-packed wound also killed the man treated next to him. Same healer, same logic, different substance, and the wound that got the treatment was the wound that went wrong. Consider cauterization, the application of a heated iron or burning oil to seal a wound by destroying the tissue around it. This was not fringe practice. It was standard procedure across Greek, Roman, Islamic, and Chinese medicine for more than 2,000 years. The logic was sound by the standards available. Bleeding kills, heat stops bleeding. The wound that bleeds stops bleeding faster when you press fire against it. You can follow every step of that reasoning and arrive exactly where they arrived. At a man screaming while a red iron is laid against his open flesh, with everyone in the room believing this is the correct decision. What they could not see was what heat does to the tissue immediately beneath the burn. It kills it. A wide border of dead cells sitting at the edge of a wound is not a sealed wound. It is a feast. Necrotic tissue is the environment anaerobic bacteria prefer above almost anything else. The same organisms that rotted an untreated wound would find a cauterized one and move into the dead margin and begin the work that would eventually become what a Roman physician might record as wound fever and what you would recognize as sepsis. The treatment did stop the bleeding. It also created the ideal conditions for the infection that would kill the patient 4 days later. The poultice problem runs deeper. Across cultures and centuries, wound healers applied plant matter, clay, animal fat, and combinations of all three directly into open wounds. Some of these substances had genuine mechanisms. Others were simply what was available and what the pattern seemed to support because the patient survived often enough to reinforce the practice. But wound survivals are noisy data. People survive despite interventions, not only because of them, and an observer without a controlled comparison has no way to separate the two. So mud went into wounds. Dung went into wounds. In several recorded traditions, including documented cases from ancient Egypt and from European practice well into the medieval period, animal dung was applied directly to lacerations, either as a poultice base or mixed with other materials. The Clostridium tetani bacterium, which causes tetanus, lives in soil and in the intestinal tracts of animals and passes readily into dung. A wound packed with dung was a wound being inoculated with one of the most lethal neurotoxins a living organism produces. The jaw locks first, then the muscles of the back and neck, then the chest. The body arches, unable to relax until something vital gives. You would not have known what caused it. Neither would your healer. Both of you would have watched the same progression in a man who seemed to be recovering, and then, around day 7, began to change in ways that had no name yet. Toxic metals arrived with the best intentions a system built on pattern could manufacture. Lead, mercury, and arsenic compounds were used in wound treatments, skin preparations, and internal remedies across Greek, Roman, Chinese, and Ayurvedic traditions. Mercury was applied to syphilitic sores well into the 19th century. Arsenic compounds appeared in wound pastes. The Materia Medica of Dioscorides, compiled around 60 CE and used as a medical reference text for 1500 years. After his death, describes mineral and metallic preparations for a range of wound conditions with the same authority it applies to plants with real pharmacological action. 1500 years, generations of practitioners, patients, and survivors and non-survivors all feeding into a system of recorded knowledge that had no way to isolate the poisoning from the disease. Here is where the cost becomes specific. In 1518, the physician and military surgeon Hans von Gersdorff published Feldbuch der Wundarznei, the field book of wound surgery, one of the most widely circulated surgical texts of its era. Von Gersdorff described wound closure practices that included suturing wounds shut before they had drained. The logic, again, was coherent. An open wound draws contamination. A closed wound is sealed from the outside world. Seal it early. What the logic could not account for was what lived inside the wound at the moment of closure. Suturing a wound that harbored anaerobic bacteria did not protect it. It sealed the bacteria into a warm, dark, airless environment and removed the body's last opportunity to expel the infection outward. The wound looked clean from the outside for a day, sometimes two. Then the tissue beneath began to die in the direction no one could see, and by the time the surface showed what was happening underneath, the margin for intervention had already closed. But here's the pivot that changes how you read all of this. These practitioners were not ignorant men making careless choices. They were working in conditions you would not recognize as a medical environment. No anesthesia beyond alcohol and opiates in cultures that had them. No sterile field, no gloves. A battlefield wound arrives packed with dirt and fabric and sometimes the material of whatever projectile delivered it. And it arrives with a man in agony who will die of blood loss in minutes if nothing is done. The decision to cauterize, to pack, to close, to apply whatever the most reliable local pattern suggested was made in seconds, in pain, in dirt, without the concept of a microorganism existing anywhere in the available world model. The practitioners who persisted in using methods like mercury or wound closure were not ignoring evidence. They were reading evidence through a system that had no mechanism for identifying what evidence was relevant. The soldier from the first section is still on the ground. His arm is still open. The healer kneeling beside him is working from the same source the honey healer worked from. Pattern, memory, what seemed to help last time. Sometimes it was honey, sometimes it was the iron, and the healer kneeling in the dirt, choosing between them with nothing but observation and urgency and everything they had been taught, was doing exactly what you would have done with the same information and the same dying man in front of you. Desperation and observation, running together, is how medicine moved at all. Some of what it found was real. Some of what it found was killing. And for most of human history, there was no clean way to tell the difference from the inside. That distinction took centuries to build, and it was built on the same raw material, watching what happened next.